Hello, and thank you for the opportunity to present the results of our prospective study investigating whether behavioural treatment benefits patients with inflammatory bowel disease and symptoms of fecal incontinence and constipation. This was conducted at St Vincent's Hospital, Melbourne, Australia. I have no disclosures. Inflammatory bowel disease, mainly ulcerative colitis and Crohn's disease, are chronic lifelong conditions with increasing prevalence. Refractory bowel symptoms are common in patients during disease remission. These are the published prevalence rates for fecal incontinence, urgency, and symptoms of constipation. Symptoms can cause distress, embarrassment, and lead to restrictions in eating, socialising, work, and relationships. Patients with persistent symptoms are more likely to have anxiety or depression, have poor quality of life, and use the health system more. Symptoms are underreported by patients, under-recognised by clinicians, and often undertreated. Behavioural treatment incorporates a number of strategies, including biofeedback, aimed at optimising bowel function. Approximately 2/3 of patients with constipation or fecal incontinence respond to this treatment, and benefit can be maintained long term. But what about patients with IBD? There are a handful of small retrospective studies reporting response rates in 60 to 80% of patients treated with biofeedback during remission. Therefore, the aim of our study, the Liberate study, was to prospectively evaluate the effectiveness of behavioural treatment in reducing the symptoms of fecal incontinence and constipation, and to assess the effect of treatment on quality of life and psychological well-being in patients with quiescent IBD. All patients who were referred for pelvic floor physiotherapy by gastroenterologists from the hospital IBD clinic were screened for eligibility. Eligible patients were 18 or older and in disease remission. Of the 55 eligible patients, 34 commenced treatment and 29 completed treatment. Treatment was paused for up to 3 months if a disease flare occurred. Treatment consisted of 2 to 6 sessions at monthly intervals and was concluded when the patient was satisfied or had attended 6 sessions. The treatment program included education, bowel habit training, defecation training, and muscle rehabilitation. Biofeedback was provided by real-time ultrasound, while some had additional rectal balloon training. Training was individualised according to patient presentation. All patients were given a tailored home program of at least 2 sessions daily of exercises and 1 session of diaphragmatic breathing and relaxation. The primary outcome was the proportion of patients reporting moderate or substantial improvement following treatment. Ratings of 6 or 7 on this 7-point Likert scale are considered to indicate a clinically significant response. Patients failing to complete treatment were assigned a score of 4 or no change in the intention to treat analysis. Secondary outcomes were completed at baseline and following treatment and included a suite of validated questionnaires assessing symptom severity, disease-specific and general quality of life, and psychological factors. The included patients had a median age of 38, were mostly female, and just over half had ulcerative colitis, and there were 3 patients with an ilioanal pouch. Median disease duration was 7.5 years. These were the key symptoms at presentation and the main targets of treatment. The predominant constipation symptoms were incomplete evacuation and straining. The median symptom duration was 3.5 years. 29 patients completed treatment with a median of 4 sessions. 21 achieved the primary outcome, giving a 62% response rate in the intention to treat analysis, with dropout patients included, and 72% for those who completed treatment in the per protocol analysis. None of the patients reported a worsening of symptoms. 4 patients who had a disease flare during the study were able to continue treatment, and 3 of these 4 achieved the primary outcome. Response rates were similar for patients by diagnosis, and none of the disease or demographic factors were significantly associated with outcome. All domains of the Constipation Score, assessing abdominal, rectal and defecation symptoms, improved significantly in both intention to treat and per protocol analyses, with a moderate to high effect size of 0.7. There was a significant reduction in the fecal incontinence score in both analyses, with a moderate effect size. The total inflammatory bowel disease quality of life score improved significantly due to the changes in the bowel and emotional domains. The improvements in general quality of life were significant in 2 of the 8 SF36 domains, indicating reduced bodily pain and improved social functioning. Anxiety scores were higher than the depression scores in the Hospital Anxiety and Depression Scale and did not change significantly following treatment. A number of patients were on antidepressant medication and had seen a psychologist or psychiatrist previously. Illness perception reflects attitudes towards illness, and there was a significant improvement following treatment. Self-efficacy reflects confidence in the ability to manage disease, and this was relatively high at baseline and did not change significantly. In conclusion, behavioural treatment significantly improved the symptoms, quality of life and illness perception in 2/3 of patients with quiescent IBD who completed treatment, and appears to be equally effective in patients with and without inflammatory bowel disease. However, long-term follow-up is required to assess whether benefit is maintained in this cohort. Thank you for your attention, and thank you to the research team and the Australian Bladder Foundation for their support.